Hello, my friends. It's Dr. Sharon with Clinic Reviews. Today we're talking about heart failure. I have done a heart failure video in the past, but this one, we're going to spend a little less time lecturing about what heart failure is. We're going to spend a little more time on the questions. The questions are, some of them are easy, some of them are harder. We are going through the Blue Book today, but I am going to talk about more than just what's in the Blue Book. But if you studied the Blue Book and you know the information there, let's see if you can get these questions correct. Hello, Clinic Review family. I'm excited to do heart failure with you today. You know this channel is a part of the greater Clinic Review organization, which offers the very best Nclex review in the entire universe, in my opinion, by Mark Klimek, who's the GOAT of Nclex prep. You can get the online on demand. You get over 21 hours of Nclex prep with the GOAT himself. You can also do streaming service, and you can also do small group tutoring. Go to clinicreviews.com to find out more about that. All right. Let's go ahead and do just a little bit of, I just want to present a few things here. So when we talk about heart failure, whenever you think about a failing organ, you have to think, what is the job of that organ? Well, the job of the heart is to pump blood out of the heart. It's to perfuse the body. Okay, it's to perfuse the body. So if the heart is failing, it means it's failing to get blood out of the heart. It's a cardiac output problem. So it's always a cardiac output problem when you have heart failure. Now, different reasons can cause the cardiac output to be decreased. Cardiac output is stroke volume times heart rate. So it's either a heart rate problem or it's a stroke volume problem. Stroke volume is either a volume problem, there's too much or too little volume in there, or it's a strength of contraction problem. Okay, the stroke itself is weak. So you can have either right-sided heart failure or left-sided heart failure. A lot of people have both. Okay, so you may see both of these symptoms in one person, but some people have just one or the other. Now, all people with heart failure have fatigue, dyspnea, and weight gain. And that's just because they have decreased cardiac output. And whenever you have decreased cardiac output, you're not perfusing your tissues as well. 25% of cardiac output goes to the kidneys. So if you're not perfusing your kidneys as well, you're going to retain fluid. That's going to cause weight gain. Dyspnea, just because the body's going to be sensing this decreased cardiac output and it's going to say, hey, we're a little tired here. So that's why everybody, no matter what type of heart failure they have, experiences fatigue, dyspnea, and weight gain. So if it's right-sided heart failure, it means there's a decreased output from the right ventricle and blood backs up to the right side of the body. If it's left-sided heart failure, you have decreased output from the left ventricle and blood backs up to the lungs first. Now, eventually it can back up to the rest of the body, but first it backs up to the lungs. So right-sided symptoms are JVD. So if it backs up to the right side of the body, you get jugular venous distension, you get hepatomegaly because the liver starts to have increased blood in it. It starts to hold on to blood. The liver can hold on to a lot of blood and it starts to hold on to it. You can also have peripheral edema. So those are classic right-sided heart failure symptoms. And then on the left side, you're going to have crackles. That's going to be the earliest sign of a left-sided heart failure. Remember, everybody's fatigued, dyspneic, and has weight gain. Now, it's either a failure to fill or a weak pump problem. So if it's a failure to fill, that's called diastolic failure. If it's a weak pump, that's called systolic failure. Remember, systole is when the heart is contracting. So if it's systolic failure, that means it's a weak pump. Diastolic means when the heart is at rest. Well, when does the heart fill? It fills when it's at rest. So if it's a filling problem, and that could be various reasons. It could be because you have decreased blood return to the heart. But a lot of times it's because there's hypertrophy of the cardiac muscle. The cardiac muscle starts to get bigger and it decreases the size of the filling, where the filling is, right? So hypertrophy can lead to decreased filling space and diastolic failure. Again, a lot of people have both systolic and diastolic failure, and we treat them the same, y'all. We treat them exactly the same. I just want you to know, in case you're getting ready to take a test, that you know the difference between systolic and diastolic heart failure. All right, let's do some questions. A patient is admitted with left-sided heart failure. Which of the following clinical manifestations is most characteristic of left-sided heart failure? Jugular venous distension, dependent edema, pulmonary crackles, or hepatomegaly? So we just went over that. If you don't remember it, just go back and review it again. But remember, it's the left side of the heart. If it's going to back up, it's going to back up to the lungs first. A patient with heart failure is prescribed furosemide. Which lab finding is most concerning to the nurse? Potassium at 3.1, so that's low. Urine specific gravity, which is low. Serum glucose, which is high, or BUN, which is high. All right, so you want to answer the question. You want to answer specific to the question itself, and it's specific to LASIK. So you might say, well, how can I choose between these? Okay, what can a potassium of 3.1 do? Can a low potassium cause any problems? It can cause cardiac dysrhythmias. That's one of the things it can cause. It can cause muscle weakness. It can cause paresthesia. So potassium is pretty serious. A high or low potassium is pretty serious. Well, if the specific gravity is low, what does that mean? It just means the urine is more dilute. That's not life-threatening. Maybe we need to do something about it, but it's not life-threatening. Serum glucose of 145, can that cause damage? Long term, it can cause damage, but it's not an acute life-threatening emergency. BUN of 45, is that life-threatening? Not even a little bit. Not even a little bit. The only one here that is significantly threatening to the patient is potassium of 3.1, and it's specific to the question. Specifically, furosemide or Lasix is a potassium wasting diuretic, which means you're prone to low potassium. Which signs and symptoms may indicate digitalis, digoxin toxicity in a patient with heart failure? Now, if you have the blue book and you already studied this, hopefully you know the answer to this. Nausea and vomiting, visual changes, bradycardia, polyuria, hyperactive deep tendon reflexes, or anorexia. Well, the one that's obvious, I think, is bradycardia. So hopefully you know digoxin is an inotropic agent. So it increases the strength of or force of contraction, which is classically used as treating heart failure. But it does cause bradycardia. It slows conduction through the electrical pathways. So you can have bradycardia. So that's the obvious one. The toxic digitalis is green, yellow halos around the eyes, like visually, like people are seeing it. You don't look in their eye and see green, yellow halos. The person sees green, yellow halos around things they're looking at. That's visual changes. So that would make sense. So digitalis toxicity could be visual changes. And then the other two that you probably just need to memorize is nausea, vomiting, and anorexia. So these are the common signs of digitalis toxicity. You just need to know it. The nurse is providing patient teaching to a client newly diagnosed with a systolic heart failure. Remember, systolic is a pumping problem, strength of contraction. So as a weak contraction. Which statement by the client indicates a need for further instruction? I will make further instruction is false, the false statement. I will weigh myself at the same time each day. Y'all, we treat systolic and diastolic heart failure the same. So they still need to weigh themselves every day. So that's a true statement. I should limit my sodium intake. Yes, that's true for all types of heart failure. I will keep track of my daily fluid intake. Yes, that's true of all types of heart failure because they're prone to weight gain. I can stop taking my diuretic when I feel better. That's false. They take a diuretic no matter the type of heart failure, they're going to take a diuretic. Remember I said we treat it the same. Really, we treat it the same whether it's right or left, whether it's systolic or diastolic, we treat it the same. But if they ask you about symptoms, that's where you're going to want to know the differences. A patient is admitted with acute decompensated heart failure. Which of the following interventions should the nurse anticipate to decrease preload? So the body can try to compensate when the heart is failing. The body can try to compensate. One of the things that it does is it actually increases heart rate, which is not therapeutic. So a lot of the things that the body does to try to compensate actually causes the heart failure to become worse. So this is saying they're decompensated. So they're unable to compensate. It's acute decompensated heart failure. So we don't know if it's right or left, right? So the question is, what will decrease preload? So this is vocabulary. You need to know what preload means. Preload is the same as end diastolic volume. Diastole is the heart at rest. End of diastole, the end of rest period, the volume in the ventricle at the end of rest. So if preload. So if we want to decrease venous return to the heart, that's essentially preload. Why would we want to decrease venous return to the heart? Because the heart can't handle it. It cannot handle that much volume. It's either weak because it's weak or because it's just got a smaller chamber. One or the other, it's a fluid volume problem, right? We got to get rid of some fluid volume. That's what we have to do to decrease preload. We decrease fluid volume because preload is the same as end diastolic volume. Okay, so it's a volume problem. Administered diuretics will decrease volume. Administering a beta blocker will not decrease volume. Providing supplemental oxygen will not decrease volume. Restricting potassium intake will not decrease volume. Okay, so the only one is to give the diuretics. A patient with chronic heart failure comes to the clinic reporting a 5-pound weight gain over the past week, which is the nurse's priority assessment. So we're concerned if they gain 2 pounds overnight, because that's water weight, or 5 pounds in a week, because that's generally water weight. So if they gain weight, it's in a short period of time, it's water weight. Okay, so what do we want to do if we think they're gaining water weight? Well, where are we going to look? Where can it show up? Well, if it's left-sided heart failure, it can show up in the lungs. If it's right-sided, it can show up in the periphery, in the liver, and JVD. So let's see what we've got here. Check apical pulse rate and rhythm. That's not looking for volume issues. Inspecting for peripheral edema and JVD. Well, there we go. That's assessing for volume overload related to the 5-pound weight gain. Assessing heart sounds for murmurs. No, that's not looking at volume. Evaluating dietary compliance. That's not looking at volume. They've gained weight. We want to know if there's any signs that the weight gain is showing up in places that it shouldn't be showing up. Which symptom is more commonly associated with right-sided heart failure rather than left-sided heart failure? So we know that all forms of heart failure have orthopnea, fatigue, and weight gain. So we're looking for something specific to right-sided heart failure, orthopnea. See, that's both. Paroxysmal nocturnal dyspnea. I don't know about the nocturnal dyspnea, but dyspnea is consistent with both. So I'm not picking that one. Peripheral edema, that's specific to right-sided. Pulmonary crackles, that's specific to left-sided. So I'm going to choose C, peripheral edema. A nurse is planning discharge teaching for a patient who has heart failure and is at risk for fluid retention. What should the nurse include in the teaching plan? Select all that apply. All right, monitor your blood pressure regularly. Weigh yourself daily at the same time. Increase your fluid intake if you feel thirsty. Restrict sodium as recommended by your provider. Take medications as prescribed, even if feeling better. Report a persistent cough to your provider. All right, so discharge teaching for a patient with heart failure is at risk for fluid retention. All right, so we're going to turn this into a series of true-false statements. For a patient with heart failure, they should monitor their blood pressure regularly. That's true, because blood pressure is essentially afterload. Afterload is the pressure against which the heart has to pump. And the higher the afterload, the more work the heart has to do. And the heart is failing. You don't want to give it more work to do. So they do have to monitor their blood pressure. So that's a true statement. Weighing yourself daily at the same time is weighing yourself daily at the same time should be part of discharge teaching for a heart failure patient. That's true. That's absolutely true. Increasing fluid intake if you feel thirsty should be part of discharge teaching for heart failure. That's false. They do fluid restrictions. Restricting sodium as recommended by your provider should be part of heart failure teaching, discharge teaching. That's true. So fluid restriction and sodium restriction. Taking medications as prescribed, even if feeling better, should be part of heart failure discharge teaching. That's true. That's just a good Nclex answer. Reporting a persistent cough to your provider should be part of heart failure discharge teaching. That's actually true. Now, the reason we teach them that is because ACE inhibitors, pril drugs, PRIL, lisinopril, enalapril, pril drugs are standard of care for heart failure. And a side effect is a persistent cough. So if they have a persistent cough, they can change their medication. A patient hospitalized for heart failure is prescribed enalapril. Enalapril, that's an ACE inhibitor. Which outcome indicates that the medication is having its intended effect? Well, what do ACE inhibitors do? They lower blood pressure. So you just want to pick the obvious answer. Potassium, no. Heart rate, no. Myocardial contractility, no. Blood pressure, yes. And afterload. Heart rate, if we want to, increase heart rate. No, we don't ever want to do that. Increasing myocardial contractility would be Digitalis. A patient with chronic right-sided heart failure presents with increased peripheral edema, jugular venous distension, and an enlarged liver, which is hepatomegaly. Which teaching point should the nurse emphasize? Elevate the legs when sitting to reduce edema. Monitor daily weights and report significant increases. Restrict dietary sodium. Consume a high salt diet to maintain fluid balance. Stop taking prescribed diuretics when swelling subsides. Avoid tight clothing that may restrict venous return. All right, teaching. This is a teaching question. So what is standard of care teaching for right-sided heart failure? Standard of care for right-sided heart failure includes elevating your legs when sitting to reduce edema. That's true. So compression elevation, doesn't matter if it's heart failure, doesn't matter what. If they have peripheral edema, we teach compression and elevation, including heart failure. So that's true. Monitoring daily weights and reporting significant increases in weight is a part of discharge teaching for heart failure or patient teaching. Yes, that's true. We teach them to do daily weights at the same time every day and report if they get 2 pounds overnight or 5 pounds in a week. Restricting dietary sodium is standard of care for teaching patients with heart failure. That's true. We restrict fluids and we restrict sodium. Consuming high salt diet. Well, we can't do both C and D. We can't restrict it and have a high salt diet. So I got to cross off D. Teaching patients to stop taking their prescribed diuretics when swelling subsides is standard of care for heart failure. False. That's not true. They're going to take diuretics the rest of their life. Avoiding tight clothing that may restrict venous return is standard of care. Well, okay. Let me think about this because that's not something I usually teach. Now, we do teach compression, but when we teach compression, it's ACE wraps or TED hose or compression stockings. When we talk about tight clothing can restrict venous return. Like if you wear socks that have a very tight area that goes around the leg, that can actually restrict venous return. So that makes sense to me. So I'm going to use my common sense. Remember, SATA questions are not about what list did you memorize. It's about, do you understand the concept they're teaching you or testing you on? So you have to use your common sense as well. So these 4 things both conceptually make sense with what I know about heart failure. And if I use my common sense, I know that that's true as well. The nurse is assessing a patient with heart failure who presents with an S3 heart sound. What does the presence of an S3 typically indicate? Y'all, I hate S3, S4 questions, but I know a lot of times they're on tests. So I decided to put it on here, even though I hate S3 and S4 questions. S3 is heard in heart failure. It's called a gallop because it is associated with increased fluid volume within the ventricles, not decreased fluid volume. Valve dysfunction is murmurs. S3 is a gallop, and that's associated with increased volume in the ventricles. A patient has developed acute pulmonary edema due to left-sided heart failure, so they've got crackles when you listen. Which intervention should the nurse anticipate? All right, pulmonary edema, which means they're probably short of breath. They may be hypoxic, dyspneic. All right, place the patient in a high Fowler's position for pulmonary edema. True. Administer IV morphine as prescribed for pulmonary edema due to left-sided heart failure. I don't know. Let me come back to that one. Encourage the patient to ambulate in the halls for pulmonary edema due to left-sided heart failure. Y'all, no, don't do that. They're in heart failure. Don't increase the work of their heart. Give sublingual nitro every 2 hours for heart failure, pulmonary edema. Y'all, no. We don't ever give sublingual every 2 hours nitro. We don't do that's not done. You can give sublingual nitro for chest pain, but we don't give it every 2 hours, first of all. Second of all, it's not standard of care for heart failure. Administer loop diuretics IV to reduce pulmonary edema for heart failure. That's true. We're going to get rid of fluid that way. Provide continuous ECG monitoring for pulmonary edema due to left-sided heart failure. Well, that sounds like a good idea because it's cardiac, right? So let's do some ECG monitoring. Remember, use your common sense. Some of this stuff just makes sense. So I know I'm going to do A. I know I'm going to do E, and I know I'm going to do F. Now let's talk about morphine. So this is the one. Now, if I want you to do one of two things, do I want you to choose over? Would I rather you over select or under select? Okay, I'd rather you under select. However, you still have to use common sense. So don't go, well, I've never heard of that, so I'm not going to pick it. Well, let's think about it. What does IV morphine do? Because we use IV morphine to treat myocardial infarction or angina. So morphine is known to decrease the oxygen demand of the heart and to decrease preload. That's what morphine is known to do. That's why we give it for myocardial infarction. So even though you may not think, well, it's not really standard of care for heart failure. Well, but they've got fluid volume overload, so we can decrease preload, decrease the overall work of the heart. I mean, that's not a bad idea. So I'm going to go ahead and pick it. Remember, I'd rather you underselect than overselect. So I don't want you to go on, well, it could be, it could be, it could be, right? For every answer. You've got to think, does it make sense? If it makes sense, go ahead and pick it. But if you can't find a very good common sense reason to pick it, then don't pick it. A patient with advanced heart failure is prescribed a combination of beta blockers, ACE inhibitors, and diuretics. Which benefits do these medications collectively offer? Afterload reduction, enhanced myocardial contractility, decreased fluid overload, improved oxygen carrying capacity, reduced heart rate, or preload reduction. All right, let's see if any of these do that. Afterload reduction is the equivalent of lowering blood pressure, and ACE inhibitors lower blood pressure. So A is true. Enhanced myocardial contractility. Well, enhanced myocardial contractility, I'd want digoxin or digitalis, and that is not here, so I'm not going to pick that one. Decreased fluid overload, that's diuretics. Improved oxygen carrying capacity. I mean, I'd have to increase the hemoglobin level, and that none of these do that. Reduced heart rate. Beta blockers reduce heart rate. Preload reduction. Well, diuretics reduce preload. So afterload reduction, decreased volume overload, reduced heart rate, and preload reduction. All right. Well, I think that is about it. So that went a little faster than I thought it was going to go. So I hope that helped you with heart failure. I know there's probably some things about heart failure I didn't talk about, but generally, this is the kind of fundamental information that you need to know about heart failure. You need to know for sure that we need to manage peripheral edema with compression elevation. We generally treat heart failure with diuretics, digoxin, and ACE inhibitors. We also can give a beta blocker if it's carvedilol. Carvedilol is the only beta blocker we give for heart failure. Okay, carvedilol is the only beta blocker we give for heart failure. We might have them weigh themselves every day, and they call the doctor's office if they gain more than 2 pounds overnight, or if they gain more than 5 pounds in a week. Sodium fluid restriction. All right. So I think that's the summary. I hope you have a great rest of your day, and I'll see you later. Thanks for being a part of the Clinic Review family.